I think melanoma is probably the most feared skin cancer and clearly, I think, the most deadliest. To discuss this topic as well as some of the newer treatments for melanoma, it's a pleasure to welcome to the podium Dr. Bartosz Chmielowski. Dr. Chmielowski is an assistant clinical professor of medicine at UCLA from the Division of Oncology. Sorry.
Okay, thank you so much. It is my pleasure to talk to you today about melanoma. And I was just thinking about it, say, why do primary care physicians need to know about melanoma? And of course, it's a part of medicine, but the majority of patients with advanced melanoma are treated by medical oncologists. So one reason I think you should know about melanoma, because there's a lot of progress in melanoma, so actually patients live much longer. And as very often we as medical oncologists take over almost as primary care physicians in patients with advanced cancers. Actually these days, because patients are doing better with cancer, there will be more of a collaboration with primary care physicians. And the new medications which we come up with come also with the new side effects, and you may face that your patients have side effects which you did not expect. So today I'm going to make medical oncologists or specialists of melanoma out of you. So we will talk about biology of melanoma, important pathways, oncologic pathways in melanoma, but also about the use of immunotherapy and the results of new clinical trials that led to approval to new drugs for patients with advanced disease. So melanoma, as you heard, is one of the deadliest skin cancers. Although it accounts only for 2% of all skin cancer cases, in 2014 we have about 76,000 patients diagnosed with melanoma. It is more common among men, so there was about 43,000 men and 32,000 women, and almost 10,000 patients died of metastatic melanoma. It is an increasing and worsening problem. The frequency, the incidence of melanoma has been increasing over the last 30 years. And this slide shows that in 1930s, the risk of melanoma was 1 per 1,500 patients, but currently in 2015, 1 out of 50 patients will develop melanoma. This increase was very steep in 1970s, 1980s. There's still a gradual increase, but it's not as steep as 20 years ago. Luckily, majority of melanomas are diagnosed as localized disease. When we use our staging system, stage 1 and stage 2, it means when the lesion is localized to the skin, did not spread outside of the original location. If we call it a regional, this is a stage 3 disease. It means when there is a spread of the disease to the local lymph nodes. And of course, stage 4 disease, these are the patients with distant metastasis. When we look here, the survival for patients who have localized disease, especially stage 1 disease, is quite good. So after a simple resection by a dermatologist, followed by usually an oncologic surgeon, you can cure this disease in more than 90% of patients. As it starts spreading to the lymph nodes, the prognosis worsens significantly, and if the patients have palpable lymph nodes, then only 40% of patients survive 5 years. These numbers come if the patients develop distant metastasis, then 5-year survival is in the range of 15 to 20%. I'm going to talk to you about the new therapies that were introduced in the last 3 to 4 years in melanoma. We exactly don't know what impact these therapies had for this 15 to 20%. We know they did, but we don't. This is a follow-up of 10 to 15 years on this patient population, so we don't know exactly what the impact they had. This is actually probably for primary care physicians for understanding the therapy of melanoma. This is the most important slide. So I want you to think about it when there are two paradigms how we can approach the treatment of advanced disease. I'm talking about the disease that cannot be removed surgically. So we can either target the tumor, and this is what we used to do with traditional chemotherapy. Now we try to understand the biology better. We try to look for the mutations and targets in the cancer cells, and target only these mutations when the therapy is usually less toxic and more efficacious. So this is the targeting the tumor. But then we can use another approach when instead of targeting the tumor directly, we will actually stimulate the immune system or change the immune system in such a way that the immune system can go where the cancer is and eliminate cancer. So our therapy does not have a direct effect on cancer cells. It is an indirect effect through the immune system. So to make oncologists out of you or molecular biologists, this is right now the most important pathway in melanoma, what we call a MAP kinase pathway. And this pathway is in every single cell in our body. A protein called RAS, which is a membrane-bound protein, is a tyrosine kinase, has ability to phosphorylate the next protein, RAF, and the one which is important in melanoma is a BRAF. This phosphorylates MEK that exists in two different isoforms, and phosphorylates ERK, which also exists in the two different isoforms. This process leads to cell proliferation and cell survival. This is a normal process. We need this pathway for our cells to proliferate. But about 10 years ago, it was discovered that about 50% of melanomas, 40 to 50% of melanomas, have a point mutation in BRAF. It's an activating mutation, and because of that, our control mechanisms over this pathway do not work, and there's a constant activation of MAP kinase pathway with increased cell proliferation and increased survival. Traditionally, when we were thinking about melanoma, we were dividing melanoma as the one arising from the skin without chronic sun damage, arising from the skin with chronic sun damage, arising maybe from mucosal surfaces, arising from acral surfaces, or the one from VI uveal melanoma. This is still a valid approach, but it has no impact on the way how we choose our therapies. So currently, it is more important to characterize melanoma molecularly because this will lead to the choice of your therapy. So we see if a melanoma starts from the skin without chronic sun damage, it means the trunk, back. These melanomas have about 50% of BRAF about 50% of melanomas have BRAF mutations. The second most common mutation is a mutation of a protein called NRAS. But if these melanomas come from the areas which have chronic sun damage, this is usually the forearms, the scalp, which are exposed to the sun, then the frequency of BRAF mutation goes down and is only 10%. If it starts from mucosal surfaces, it's only 5%. If it is an uveal melanoma, we do not even test for BRAF mutations because BRAF mutations are not found in the eye melanoma. There are other mutations called GNAQ and GNA11. As we understand molecular biology, we know that there are more and more mutations. So one of the proteins of interest is a protein called KIT. This one is much more frequently mutated when melanoma arises from the mucosal surfaces or from palms or soles, but it's never present when melanoma arises from the skin without chronic sun damage. Why do we want to know? Because, of course, we know we developed BRAF inhibitors. Initially, they were not very successful. Then finally, it led to the development of a drug called vemurafenib. And here at UCLA, we're involved in the development of all the medications I'm going to mention today. The standard chemotherapy for patients with melanoma in 2011 was the drug called dacarbazine, with a response rate of 5 to 10%, and a median progression-free survival for this patient was about 3 months. So these patients were randomized in a large trial in 1-to-1. Actually, this is interesting. I was thinking about it. I was listening to some of the previous presentations, and I hear 10,000 patients were tested or 5,000 patients were tested, and we saw the difference between the curves. So we don't have, 675 is one of the largest melanoma trials. So this is the example of one of our UCLA patients who presented with a large axillary mass of probably about 20 centimeters in size, and was started on vemurafenib, a BRAF inhibitor. Of course, we first tested the melanoma, it had BRAF mutation, and then 3 months later the mass is gone. Starting with this therapy, we come up with a term that was called the Lazarus effect, and I'm not sure how many of you are Christian, but then when you know that Jesus brought Lazarus to life, and very often patients who are very symptomatic, a few days after starting the therapy are feeling better. So, and we see, of course, it led to the results of this trial. When with standard chemotherapy, as you see, the curve goes steeply down, but the patients who are on vemurafenib have a progression about 5 to 6 months. As you see, the disease continues to progress. So it's not a cure for the disease. They live longer, their symptoms are better, but unfortunately, the majority of patients become resistant to the drug. So if we look at the survival, it's also a significant separation. Here we have a 6-month survival, which was 84% for patients on vemurafenib and 64% on the traditional chemotherapy. And you remember we were talking about 15 to 20% 5-year survival for patients with metastatic melanoma. As you see, we are using, for our oncology trials, we use something what's called RECIST criteria, and this is how we assess response. So for us to say that the patient is responding, the shrinkage of the tumor must be at least 30%. So if it's shrinkage 29%, we call it a stable disease. But when you look, so the response rate was 48% on vemurafenib. But when you look here, almost 85% of patients had some shrinkage of the tumor. So it tells us, and with chemotherapy, this is a minority of the patients. So it tells us when it proves that if we can find the mutation, we know what's the driver for the growth of the tumor, and we find the right drug, majority of patients may respond. And this is probably the more important slide for you also, is these drugs come off with side effects. Almost 40% of patients require some dose reduction of a drug or dose interruption. And the main side effects was actually joint pain. Joint pain is very interesting in these patients. It's very often a migratory arthralgia. They say that they come, oh, my elbow is hurting for 2 weeks, and then they come, and when the wrist started hurting, their elbow got better. Over a period of time, as they stay on the drug for a long time, they may develop joint stiffness. And the more they exercise, the better for them. Also, they develop macular rash, where they develop lesions which resemble warts on the skin. And then later on, skin turns, it's kind of rough to touch and kind of feels like a sandpaper. They may develop some fatigue. Most importantly, actually about 30% or 15 to 20% of patients develop another cancer, squamous cell carcinoma of the skin, when they are using. No one died of this, but some patients require several dermatologic interventions to remove squamous cell carcinoma of the skin. So this is vemurafenib. The second drug which was following vemurafenib is dabrafenib, and the result of this trial will be very similar. That's why I'm going to spend slightly less time on it. But it's, again, compared to the same chemotherapy drug, fewer patients because the magnitude of response was, we saw that the magnitude of response was very high. And you see a very similar separation of curves between dabrafenib and dacarbazine in chemotherapy, which tells us if drug blocks the pathway, it's not really the type of the drug. It's kind of like you have different statins and you can achieve the same LDL reduction, just they have different names. Okay, and then very similar magnitude of response. As I told you last time, we had a number of 48%. Now we have 50% as a response rate. And if the bar goes down, every single patient is 1 bar, so all of these patients had reduction in the size of the tumor. It also comes with side effects. Side effects actually are slightly different. Also skin reactions. Also rare squamous cell carcinomas, but less common than with vemurafenib. This is not a type of chemotherapy, so we don't have so much nausea, vomiting. We don't have drop of white blood cells, drop of platelets. If we do, these are of minor degree. These are usually not clinically important. So I showed you the pathway. I showed you the pathway. The BRAF, activated BRAF, the next protein kinase in this pathway is MEK. So people say, maybe we should try to block the pathway downstream, not necessarily at the level of BRAF. And that's why it led to the development of a drug called trametinib as a single agent when it was compared to chemotherapy. This trial was done mainly in Europe because in United States, BRAF inhibitor was already approved, so it will be difficult to randomize to chemotherapy. But as you see, the curves are somewhat similar. The response rate is slightly lower with MEK inhibitor alone, but also it leads to improvement of overall survival when it is compared to a standard chemotherapy. But as I told you, these curves, although there is a magnificent response and a majority of patients have some shrinkage, the curves continue to go down. So it means that the disease is coming back in these patients. So we spend a lot of time and effort here at UCLA. We try to biopsy the patients before we give the drug, and as they go on, as the disease progresses, rebiopsy and reanalyze the tumors to try to figure out what might be the mechanism of progression of the disease. So if we have a pathway, then when we use our BRAF inhibitor to inhibit the pathway, suddenly we see that as melanomas are heterogeneous up front, the mechanism of resistance to the drug are also heterogeneous. So it's not one mechanism of resistance. Some of these melanomas developed additional NRAS mutation, and this NRAS mutation, as I told you, BRAF is not only RAF protein, not the only RAF protein. There's also CRAF. NRAS can activate CRAF and reactivate the pathway. Other patients had melanomas when there was amplification of BRAF, and the amount of drug which we delivered was not sufficient to inhibit the whole BRAF. Others had mutations actually downstream in MEK, and other was alternative split forms of BRAF, and BRAF stopped working in these patients. This is, again, a concept that if we understand the biology, we can make a difference. So as I already told you, we are inhibiting in these patients BRAF and inhibiting the whole pathway, and it stops melanoma from growing. But also I told you when we're using vemurafenib, about 15 to 20% of patients may develop squamous cell carcinoma of the skin. So we biopsied this squamous cell carcinoma, and actually these results were published in New England Journal of Medicine, and we saw that in the majority of the squamous cells, we found an HRAS mutation. So this is a pre-existing mutation, which in a normal situation, when you don't have, and it comes from the sun damage, so because squamous cell carcinoma usually occur in the areas with a severe sun damage. So it is under control, but if you start using BRAF inhibitor, this starts sending the signal and bypasses BRAF inhibition through the molecule called CRAF. And it reactivates the pathway. So where the mutations were, the cells start proliferating and creating squamous cell carcinomas. So I said, okay, so if this really reactivates the pathway, if we could try to block downstream, maybe we can stop this process, because it goes also through MEK. That's why we started, well, this is one of the reasons we started using a combination of a BRAF inhibitor and a MEK inhibitor in this patient population. So sometimes people say, why would you do it? It's the same pathway. You are already inhibiting. But because there are bypass pathways which can reactivate the pathway. So this is an example of our patient who developed multiple squamous cell carcinoma. So this is one of these patients which is, is not as easy because she required like 20, 30 surgeries to remove them. When we started using MEK inhibitor, then we blocked the pathway here, and this is her leg after we added MEK inhibitor to BRAF inhibitor. So it proved the concept, again, when we understood the biology, why squamous cell carcinomas occur, and if we use another drug, we can stop their growth. So it led also, but also I told you that some of the mechanisms of resistance are going through reactivation of MEK. So the concept where maybe in one drug is not enough. And that's why a big trial was undertaken of combination of a BRAF inhibitor, dabrafenib, with MEK inhibitor, trametinib, versus BRAF inhibitor plus placebo. For us, it's a large trial, had 947 patients. The difference is less spectacular than in patients, of course, comparing to almost not active chemotherapy, but we also see when there's an improvement in progression-free survival when combination is used versus one drug alone, and is 70% versus 57%. We also see when we have a very spectacular, very often responses, and in many patients they can be prolonged. So we see when many patients progressed, but we have a number of patients who've been on the combination of drugs for 3 to 4 years, and this is one of our UCLA patients who presents with an enormous flank mass. When 2 months later, as you see, when it started on combination of a BRAF and MEK inhibitor, the mass is almost gone, and this is a year later after starting the therapy. Still, you see where the mass was, but you cannot really detect melanoma. Also, there was another clinical trial when dabrafenib plus trametinib was compared to the other BRAF inhibitor, vemurafenib. This separation, of course, as we said, is smaller, but it is significant. That's why currently in patients whose melanomas have BRAF mutation, if we use oral therapy, then we use combination of a BRAF inhibitor and a MEK inhibitor. Interestingly, as we talk about it, there is a change in the profile of side effects. Normally, we would say you use 2 drugs, you should have more side effects. But I already showed you that some of the side effects come from the bypass pathways. So actually what we see that, for example, the frequency of squamous cell carcinomas when you use 2 drugs goes significantly down, but there are new side effects on this group on combination of drugs, which is fever. About up to 70% of patients may develop fever a few days to few weeks after starting the therapy. Sometimes they are just feeling feverish, and that's okay. But occasionally they can have a fever as high as 103 and 104. And this is so these patients will come to the emergency room and they will come to your office, and they will really look like infected patients. But we've gone, when we were developing drugs, we were admitting these patients to the hospital and saying probably they have overwhelming infection. Actually, you stop the drug and the fever goes away. It may take 2 or 3 days. Of course, if the patient is really hypotensive, then you admit the patient. But we've never found any infections. We do not understand what's the mechanism of this fever. We see it more often in patients who have brain metastases. So this is the pathway I was talking all the time about. But the situation is more complicated. It was a breakthrough for melanoma, but we right now see when this is not the only pathway. RAS can also activate PI3 kinase AKT pathway, which some melanomas may have loss of PTEN. This activates bypass pathways. So actually, as we analyze melanomas, we find more and more mutations. And that's why we are going into more and more combinations with new drugs like AKT inhibitors or P16 inhibitors or even KIT inhibitors together with it. So this is what we call targeted therapy. But then the rest of my talk I want to spend on immunotherapy. So again, right now we are not directly targeting the cancer cells, but we are changing the immune system. Probably actually, let me spend a few seconds on it. And I'm sure in your office, if you have a patient with cancer, this happens the same. In my office, it happens every day when a patient is newly diagnosed with cancer. They always ask, what happened to my immune system? Can I drink a juice to boost my immune system to get rid of cancer? Can I take a pill to boost my immune system? So the truth is, when very few cancers are caused by failure of the immune system. Some of them are. When we had patients with advanced AIDS, of course, they were developing the cancers. When we have patients after organ transplant on chronic immunosuppression, yes, they have increased frequency of cancers. But majority, 99% of our patients with breast cancer, lung cancer, colon cancer, they do not develop infections. So this is not a failure of the immune system. It is an active process of evasion by cancer from the immune system. So as the cancer is able to develop mechanisms to outsmart the immune system to evade our very well working control. So we are trying right now to outsmart cancer and change this immune system to try to eliminate the mechanism of evasion. So actually, again, another gossip said, 20 years, almost 20 years ago, I started doing my PhD in immunology. And the chairman comes and says, hello, there's no future in immunology. Why would you like to do it, I persisted, finished, got my PhD in T-cell development immunology, and these days, I'm not sure if you listen, but if in oncology, right now, all the oncologists come to say, how should we do this immunotherapy in breast cancer? How should we do it in lung cancer? How should we do it in kidney cancer, and so on? So immunotherapy is right now a hot topic in oncology. So what's happening? Of course, it must be an immune response. So the T cells, usually CD8 positive cells, are responsible for destruction of the tumor. They go to the site where the tumor is, and this interaction is antigen-specific, so you have a T-cell receptor that recognizes MHC class 1, usually sometimes class 2 on CD4 cells, plus a peptide. But this is what we call a signal 1. But there are more, right now we know that there's a myriad of different molecules which are co-stimulatory molecules. We are co-stimulatory or co-inhibitory. We have the molecules which are responsible for inhibition of the immune system, and activation of the immune system. Sometimes when I talk about these new therapies to my patients, I tell them, we need to have this control mechanism. Otherwise, you would develop flu, you have your fevers and chills, your immune system is fighting the infection. But your virus is gone, and if we don't have anything to stop this immune system, you would have fever for the rest of your life, and you will not, because it will be going on and on. So we need to have natural inhibitory mechanisms, and cancer very often uses this to evade the immune system. So this is a little bit more of immunology. I already told you about this interaction between T-cell receptor and MHC as a signal 1. But there is also another molecule called CD28 that interacts with a molecule called B7. This is what we call the signal 2, which is required for activation of the immune system. And this leads to T-cell activation. There is another molecule called CTLA4. Normally it's not expressed on T cells, or it's expressed on a very low level. But this is our natural brake mechanism. So if the responses go on, then the CTLA4 level goes up on the surface. It goes up on the surface, it has higher affinity to B7 and displaces CD28 from the interaction with B7 and sends inhibitory stimulus to the T cells. T cells stop responding. So now we come up with a monoclonal antibody called ipilimumab, and we block the CTLA4. So it's not a direct activation of T cells, it's actually a removal of inhibitory mechanism on your inhibited T cells. So this led to this clinical trial when patients on ipilimumab were compared to patients treated with a vaccine as a control arm. And at 1 year, right now, patients receiving ipilimumab had a survival of about 45%, and if they received the vaccine, which was considered inactive arm, 1 year survival was 22 to 24%. So right now, we have an improvement from about 25% to 45% in 1 year, and there was also improvement at 2 years, which the difference was about 12%. But now side effects, and this is for you probably the most important part. This is not a specific activation against cancer. We reactivate cells that were inhibited in our body. If the cells were inhibited for another reason, not to fight cancer, they will get reactivated too. That's why almost all side effects look like immune-related adverse events, so it look like autoimmune diseases. So there is no nausea, no vomiting, no hair loss, nothing like that, because it's not chemotherapy. But very new side effects come. There is an inflammation of the bowel that can look as a severe Crohn's disease or ulcerative colitis, autoimmune hepatitis, autoimmune hypothyroidism, hypothysitis. And all of this, when we did biopsy, we found the infiltrate of the immune cells. Luckily, at least half of the patients have completely no side effects, to the degree that they come to the office and say, are you sure you are treating me because I just come get my drug and go home? But 15% can have severe to life-threatening, and there were patients who presented with severe colitis, and it led to perforation of the bowel and death. If we use prednisone in patients who have severe side effects, in 95% of them, we can reverse them. But this is important, and actually, so anytime I tell my patients that this is somewhat the mechanism of action is somewhat new for community physicians. If you go somewhere, if you have side effects, make them call me. Because very often patients comes to emergency room and has 15 bowel movements a day and started 3 days ago or 4 days ago. What we do, or maybe you have E. coli infection, maybe we should give you some Cipro, do cultures. But what you have to do is actually to give high-dose prednisone, because the longer they have colitis, the higher the risk of perforation. So this is something that you may encounter as these patients live longer and they suddenly present. They say, oh, you know, the doctor, my oncologist is treating me with immunotherapy. And now I have 15 bowel movements a day. So prednisone would be the treatment for this. So this is the list of side effects. I mean, theoretically, we've seen everything. uveitis, something that looked like rheumatoid arthritis. I had one patient who had encephalitis, actually, aseptic meningoencephalitis. So it can be endocrine glands are commonly affected. So hypophysitis, thyroiditis, adrenal insufficiency. Enterocolitis is one of the most common side effects, but also can be hepatitis, pancreatitis, dermatitis, occasionally pneumonitis, and then also neuropathy, but it will be like inflammatory neuropathy. But as I said, almost any organs. The most frequently, bowel, skin, endocrine glands, and liver. But liver is only like in fewer than 2% of patients. Also, because the side effects come from the activation of the immune system, they don't happen at the time of infusion. So it's not like the severe nausea, you gave chemo and patient starts vomiting, because the immune system needs time to get activated. So as you see, these are the curves of occurrence. We start here, the treatment here, give 1 dose every 3 weeks, but very often the side effects may happen 7 to 10 weeks after you started. So it's important to know it, because it says, you're already on the 3rd dose, and now suddenly you have elevation of liver enzymes. It's impossible, it's the drug, because it is possible, because the side effects can be delayed. But this is what excites us. You know, when we see that if 2,000 patients were treated with this drug, maybe the responses are not so frequent, but about 22% of patients survived 3 years. And if they survived 3 years, almost they never relapsed. So these responses can be durable. So it's not, with targeted therapy, we saw that most of the patients responded, but the disease progressed. Here, fewer patients respond, but if they respond, then this response can last for a very long time. Actually, the first patient in the world treated with this drug was treated in our office at UCLA. It was 12 years ago. This was a woman with lung metastasis, and she is still alive. She's on covers of Forbes or whatever, all the magazines. And so she received only 1 dose of this drug. So which is the first patient, and she's still alive. But now we understand that this immune system is more complicated. So I already talked to you about this interaction between T-cell receptor MHC, the CTLA-4, and the use of ipilimumab, CTLA-4 blocking antibody. But as I showed you in the first slide on immunotherapy, there is a plethora of different molecules. One of these molecules, and this is what's the hottest topic right now in all the news, is a molecule called PD-1. PD-1 is a natural inhibitory molecule on T cells again, so we use it to inhibit the delayed responses. But also what we see that many cancers actually express the ligand for PD-1. So this is the mechanism of evasion. The cells survived because they had the ligand on the surface for the inhibitory molecule on your T cells. So although the T cells go where the cancer is, they want to destroy it, they get actively inhibited. So, of course, what we were going to do, we are going to block this interaction by use antibodies either against PD-1 or on the other side, PD-L1. And this is, we were involved in the development of pembrolizumab. This is a complicated phase 1 clinical trial, which has a total of more than 400 patients, where we're testing different doses and different schedules of the drug. This is our patient who actually ended up on Fox News, but when the drug was approved, who presented to us with a severe condition with a large heart mass and pleural effusion. And as you see, this is a year later, but actually he started feeling better about 6 weeks after we started the therapy. And we cannot find the disease at all. This is a large hepatic mass, which he had at the time of when he came to our office, and the mass is gone. And it's not the patient who just was diagnosed. He was already receiving several therapies for metastatic melanoma. This is, again, the waterfall plot, which starts resembling the plots of targeted therapy. When we see about 72% of patients had some reduction of the tumor when we use anti-PD-1 antibody. This is my patient actually with something what's considered a melanoma resistant to therapies called desmoplastic melanoma that has a tumor growing on his cheek and an enlarged lymph node here. And we started treating him with pembrolizumab. And as you see, 3 months later, we can detect only the scar after the therapy. So again, it's not a direct effect of the drug on cancer cells. It's only through the immune system that the immune system goes where the cancer eliminates cancer. So now this is the survival curve, and I'm not sure if you remember, I was telling you 25% is usually 1 year survival. When we started using ipilimumab, it's 45%. Now we have a 12-month survival of 70%. So this is a progress in melanoma. There's another drug. These are the data from phase 1 clinical trial called nivolumab. Actually, both pembrolizumab and nivolumab are right now approved. Then this shows this very similar benefit. I'm talking only about melanoma, but now we know that this benefit extends beyond melanoma. Nivolumab is already approved also for lung cancer, but it's kidney cancer. It's being tested in head and neck cancer, bladder cancer. So it is not cancer specific. As long as the cancer uses this immune PD-1, PD-L1 interaction to evade the immune system, the drug can work. And it's not only that it works in so many patients. Again, the responses are durable. So 54% of responses at the time of publication of these results were ongoing. The responses occur frequently, so within 8 weeks from starting, rapidly, within 8 weeks of starting of the therapy, patient already had responses. And majority of these patients, they had responses that lasted more than 1 year. So it is most of the patients, and the responses are durable. We had also another trial comparing again to the standard chemotherapy. And although, initially the progression was similar between immunotherapy and chemotherapy, what the difference is when if they at like 4 months, the curves separated and fewer patients on immunotherapy progressed than patients on chemotherapy. Almost everybody progressed. This was the data on pembrolizumab, now the data on nivolumab. Again, the trial done in Europe because we wouldn't randomize patients in first line to chemotherapy anymore in the United States. But you see this significant separation. And again, 1 year survival is in the range right now of 70%, and with chemotherapy alone was 40%. So of course, medical oncologists say, we have to imagine that PD-1, PD-L1 will not be the only mechanism the tumor uses to evade the immune system. We know that CTLA-4 blocking antibody can work in this patient. So what about if we try to block this immune evasion in 2 different places, through CTLA-4 and through blocking PD-1. So this is the results of the early trial. We are waiting for the results of the larger randomized trial. It's been completed. We just don't have data yet. And now we see if 2 drugs were used in combination, the 2-year survival is 80%. So we went from 1-year survival, 25%, to 45%, to 70%, now to 2-year survival of 80%. So this is, in this short talk, I try to make oncologists out of you, but I try to put it also in perspective. And the field of oncology is changing very, very rapidly. And since 2011, so only the last 4 years, we have 6 new drugs approved just for metastatic melanoma. There are 2 BRAF inhibitors, 1 MEK inhibitor, anti-CTLA-4 antibody, ipilimumab, and anti-PD-1 antibodies, pembrolizumab and nivolumab. There are other anti-PD-1 antibodies. We are targeting other co-stimulatory and co-inhibitory molecules in the immune system. So combinations will be coming, and we are making progress. You will be seeing them, because of these patients will live longer, you will be seeing them back in your offices. Because right now, in many of this, I remember, when I started and I was telling, I have this chemotherapy pill, the chances are that you're going to respond 10%, you shouldn't lose hope, let's do it. But now we see, so of course, the control of blood pressure, control maybe of cholesterol at that time in these patients is somewhat less important because they will not be dying of hypercholesterolemia 10 years later. They are dying of metastatic cancer. But as we do better job in treating cancers, actually then control of blood pressure, control of sugar, control of cholesterol becomes more and more important for these patients. But second, also these drugs come with a different side effect. So when visitors say, okay, now I'm going to give you an anecdote somewhat. I have a patient who has oily bowel movements, and then he had diabetes on metformin, and his sugar is going up. And I called to his doctor, said, you need to start giving him insulin. No, I'm going to give a second-line oral medication. I said, no, it's an autoimmune destruction of his pancreas. So you need insulin because he's destroying his islets, with the immune system. No, we ended up with patients right now only on insulin. But it takes a little bit of a learning process to see because, of course, 65-year-old man suddenly developing type 1 diabetes, no one wants to believe in it. But with these drugs, it can happen. This patient actually happened to also develop exocrine pancreatic insufficiency, so required creon to support him with pancreatic enzymes. These are rare events, so even for oncologists, we don't see it every day. Luckily, these side effects are not as common, but they can happen. So there will be also new side effects for primary care physicians. Okay, that's all. Actually, I finished before my time. Yes. So actually, if there are, so the question is, can we use viruses to improve immune responses? I did not talk about the whole cancer immunology, but one of the first steps in activating the immune system is presentation of the antigen and availability of the antigen. There is currently a vaccine called TVEC. And this is a herpes virus, which is modified, but can proliferate in cancer cells, but cannot proliferate in normal cells. So it requires intratumoral injection, but then we think that it stimulates the immune responses because we saw responses not only in the injected tumors, but also in tumors outside of the not injected tumors. Actually, the company is filing for the approval. There was an improvement in the duration of the responses, but this improvement was small. So this is we'll see if it's going to get approved. We are combining this vaccine right now with ipilimumab and pembrolizumab, and we see that this benefit is tripled. So we see that probably alone, the virus alone will not be sufficient, but maybe if you try to manipulate immune system in 2 different places, it will be. There are other, I'm sure you heard about measles virus, polio virus, people are trying to inject different cancers. It's a lot of publicity. It's still not in the clinic. I mean, like not for the use in patients. But yeah, I mean, it is in clinical trials, so you have the injections and that. But the responses are rare, rarely spectacular, but they are still very rare.
Back.
Yes, oh, sorry.
Talking about publicity, in Colorado, there's a lot of publicity looking for men who are developing melanomas on Viagra for class action suits.
Yes.
I don't know if you're really seeing an increased incidence on Viagra and melanoma.
Okay, so actually very good question. This is so funny because I was approached by a law office to analyze, can we do a lawsuit for Viagra? So there is one publication. There is one publication showing that there was increased frequency of melanomas, primary melanomas, in patients who took Viagra. Of course, this is all retrospective. I mean, it was actually prospective looking at the data, but patients were not randomized. We exactly don't know why they took Viagra. And there is a lab data showing that medications like Viagra, so phosphodiesterase inhibitors, can activate this MAP kinase pathway I was talking about. But this was tested, so there is some biology behind it, but this was tested in metastatic lesions, and the clinical data show on development of a new lesion. So this is completely different biology behind it. So yes, there is some data. The data is not, I mean, we cannot prove, but we cannot ignore it. We cannot ignore it. Yes, sorry.
First question, if I'm working primary care, urgent care, and I see this immunological mimic process, what dose of prednisone do I use? And 2 comments. Number 1, I think tanning beds should be outlawed. And to wszystko jest niesamowite.
Yeah, to jest niesamowite, yes. So, so yes, so what dose? If also depends, they are in different intensities. If somebody comes with 3 bowel movements a day, I sometimes say, okay, take some Imodium, but just don't disappear, call me what's happening tomorrow. If it's 10, 15 bowel movements, then I give 1 to 2 milligrams per kilogram. So it's a high dose, 1 to 2 milligrams per kilogram. If they are really occasionally very sick, then I give like 125 to 250 milligrams of IV Solumedrol. Then but these are very sick patients who get dehydrated and so on. But usually 1 to 2 milligrams per kilogram of prednisone, so 60 to 100 milligrams of prednisone a day is sufficient. And so you do it. So the question is how long also I should do it. When you keep the high dose until they improve. When they improve, you start titrating down because and usually it takes about 30 days to wean them. If you taper too fast, then they may recur. Unless you have something that you give a prednisone and next day they are much better, then you probably can do it faster. But if it takes several days to get it better to normal bowel movements, then you start tapering down and slowly over like 30 days. And tanning beds, yes, tanning beds should be banned. I kind of support also something what's called AIM at Melanoma, which is a foundation. And in California right now, at least people under the age of 18 must have a parental permission for use of tanning beds. But tanning beds are not good for you. Thank you.